I think with no further ado, we will start the presentation. Thank you all very much. It's going to start with me, so you'll hear me too in a moment. So, of course, a project like this can't happen without the assistance of a very large number of people. We'd like to thank especially the participants in this research, which include both the older carers and the principal social workers and safeguarding leads and others who so kindly gave their time and spoke to us at a time of very high stress. We would also like to thank our advisory board, our project partners Tide and Making Space, and then a number of people who helped us enormously with recruitment, Join Dementia Research, the Clinical Research Networks, ADAS, Carers UK, the Alzheimer's Society, and the multitude of professional organisations and carer groups that assisted. They're all listed in our report. And thanks also, of course, to our funders, the NIHR and the ultimate funders, DHSC, and to the Policy Research Unit, Older People and Frailty, have given us so much help. So just by way of very brief background to explain what easements are and what actually happened. The Coronavirus Act 2020 included an unprecedented power for local authorities to temporarily suspend the majority of their adult care, social care duties required under the 2014 Care Act. And these suspensions were known as easements. What actually happened was that 8 local authorities enacted either stage 3 or stage 4 more severe easements in April 2020. But most of these were very short-lived, some only a week or a couple of weeks, and the longest was 3 months. And after that period, although the legislation was in force for quite a long time, for a couple of years, no further easements were enacted. So with this project, what we were trying to do, our primary objective was to investigate the impact of easements on this particular group of older carers and on those responsible for safeguarding within local authorities. But we had 4 secondary objectives: to document the impact of Care Act easements and the reinstatement of statutory duties when they were lifted, to compare and contrast experiences in local authority areas with easements and those without, to understand the challenges and dilemmas for those with safeguarding responsibilities, and to understand and document urgent challenges for carers and for local authorities. And we did this in 4 principal ways. The fieldwork was carried out between April 21 and July 22, which will become more material you'll see a bit later. So we did 48 in-depth interviews with people themselves over 70 who'd been supporting their spouse or partner living with dementia to live at home. And they were split between easement local authorities and non-easement local authorities. We undertook in-depth interviews with 27 either principal social workers or safeguarding leads or others in leadership at 20 local authorities, again split between easement local authorities and non-easement local authorities. And then drawing on the qualitative work, we have a national survey of caregivers who were supporting a family member living with dementia at home. And this, we got 604 full responses with very high quality data. This, of course, was not a random sample. And so we'll be talking more about that a little later. But it was a very, it's a substantial sample, and we employed a lot of different methods to try to reach caregivers. And then we undertook legal analysis of the operation of the Care Act. And so with that background, I'm very pleased to hand you over to Jane, our Principal Research Associate, to outline the findings from the carers arm of the study. So Jane, I'll hand over to you.
Okay, thanks, Debbie. So I'm just going to talk through some of the key findings from the interviews that we undertook with co-resident spousal carers and the findings from the survey of family carers supporting a family member with dementia to live at home. So the data from both of these aspects of the study kind of support 3 broad sort of overarching findings. So firstly, that the carers and the family member that they were caring for experienced a significant reduction in the care and support that was previously available to them prior to the onset of the pandemic. Secondly, that carers' experiences were similar across local authority areas. So we found like no notable differences between the experiences of carers living in easement and non-easement areas. And thirdly, that the respondents reported really quite low levels of well-being. Next slide, please. So in what way did the availability of carer support change? Well, much of the carer support provided in the home was either reduced or temporarily stopped. In respect to home care, very few of our respondents reported that the local authority had sought to reduce home care visits. However, several carers told us that they had made their own decision to temporarily suspend or delay or stop visits from home care. This decision, it was most often based on concerns regarding the risk of contracting COVID from home care workers, and given the significant risk that COVID presented to themselves and their partner, taking into account that both parties were aged 70 plus. Some carers, they highlighted the existing challenges that they were already experiencing in respect of home care, so factors such as high turnover of home care workers, lack of consistency, concerns regarding PPE, and those factors became increasingly problematic and risk-laden in the context of the pandemic, and particularly at the beginning prior to the development of the vaccines. And for the carers that made the decision to stop or suspend support from home care, they were then required to step in and meet the resulting care deficit. And sometimes that was with the support from wider family, but sometimes not. And this was also happening whilst other forms of in-home support, such as friending and sitting services, were also suspended. And for carers that simply felt unable to reduce home care involvement because of the partner's levels of needs, the concerns regarding the risk of COVID caused real anxiety. Right. And in respect of in-person support groups and day centres and daycare, all of the interviewees that we spoke to reported that these services had been suspended. Carers often stressed the real value of these services for both themselves and their partner. For carers, this was primarily in terms of enabling them to have a break from caring for their partner, highlighted in the quote on the slide here. So one respondent said, my partner, she went to a day centre, for 5 hours, and that was just a release valve to me. Just getting 5 hours was like 2 weeks, and as soon as I dropped her off, it was a weight off my shoulders. And many carers described having no real opportunity to take any kind of break from caring for their partner whilst these services were closed. And for the person living with dementia, carers felt that the day services, they offered a really valuable opportunity for their partner to socialise and engage in activities. And many carers believe that their partners had experienced an accelerated cognitive decline due to the lack of interaction and stimulation that they've been able to access during the lockdowns. And some carers, they did report having been offered alternative online provision, including online support groups or activity sessions. And while this was always appreciated and welcomed, many carers felt that these alternatives, they didn't really meet the needs that were being met by the previously face-to-face service. Carers often reported that the person they cared for struggled to engage with the online groups, required a lot of support to be able to do so, and that as a consequence, supporting their partner to engage in the groups had added to their caring responsibilities rather than providing any sense of providing a break or a period of respite. And this can be seen in the survey data too, which indicated that out of 100 survey respondents, they were offered an online alternative to a previously face-to-face provision. 81% reported that the experience was worse for one or other or both themselves and the person that they cared for, and more than half, so 52%, reported that it was worse for both. On the other hand, online support groups for carers themselves were evaluated more positively by some carers who found the online provision to be more accessible, but this wasn't universal by any means. So in respect to residential respite, again, it reported to have been initially reduced and very difficult to access, particularly at the start of the pandemic. And again, it was the perceived risks of contracting COVID within a care home environment, coupled with concerns regarding restricted visiting and periods of isolation, meant that some carers made a decision to decline respite that they'd previously been assessed as eligible for. And it's highlighted in the quote there on the slides. So this interviewee said, 2 of our friends, their husbands went in for respite, and unfortunately it was when everything went into lockdown and they've never come out. So the home said, they are still alive, but the home said, well, really they've deteriorated because they couldn't see family or anything, and they just weren't fit to go home, and I'm not prepared to let that happen. and the outcome of it being that some carers felt unable to have the periods of respite that they felt they desperately needed. So if we just turn to consider how the qualitative findings are reflected in the survey data, as Debbie said, this wasn't a random sample, but it was quite a substantial sample, and we did use multiple routes to reach older carers, supporting a family member to live at home with dementia in a range of circumstances. It's also important to bear in mind that the survey was conducted in April to July of 2022, so some 2 years after the pandemic began. This is an extract of one of the tables in the report, and you can see here when we consider the people who were those people who were receiving certain types of support before the pandemic, whichever kind it was. So on many indicators, half or more of those people were now receiving no support at all. And bearing in mind that dementia being a progressive disease, and so you might expect to think these families were now in greater need. And you can see that many of these services would have been helping to relieve the stress on carers, especially befriending, sitting services, respite days and day centre days, and there are more listed in the report. And then also of note, we can also see there's substantially less support for these families from social workers and GP services. We also measured, among other things, how carers were managing using the relative stress scale. And the relative stress scale is a formal way of evaluating what you might think of as red flags for care situations approaching or at breaking point. And so just to highlight some of these findings, they show a very difficult situation for the respondent carers. And just to pick out a few, for example, more than 90% of respondents felt that they needed a break, and nearly 80% said that their own health had suffered, and more than 75% indicated times when they felt they could no longer cope with the situation. And we also took a number of other measures commonly used in surveys and as clinical screening tools, which also suggest quite a challenging situation for carers. Now, we do know, of course, that everyone was suffering in the pandemic, and so for comparison purposes, we also looked at some of the same measures used in the COVID-1 sub-study of the English longitudinal study of ageing, so ELSA, for the population over 50. And what you can see from the table here is whereas 23% of older people were experience high loneliness, this was shown in 57% of our survey population, and whereas 9% of the population reported high anxiety, such that it might trigger the need for a clinical investigation. This was 37% amongst our carers. And when we look at high scores on depression screening, that would suggest the need for clinical investigation, 22% amongst the wider population, but 60% of the survey respondents. And it becomes even more notable when we separate the data for co-resident carers as opposed to carers living outside of the home, where 62% are extremely lonely, 40% have high levels of anxiety, and 71% have reported red flag signs for risk of depression. So just a final slide from me. Overwhelmingly carers described having experienced real challenges and difficulties, yet some carers were relatively more able to navigate these difficulties than others. So many carers highlighted the crucial role of the family, the friends and neighbours in supporting them practically and emotionally, and highlighted positive experiences of support from a wide range of sources like carers hubs and charities and carers organisations. And having an existing relationship or contact with a known person or service that could be contacted for advice if circumstances change was described as really invaluable. And conversely, the absence of this, a feeling of I don't know who I would contact if I needed to, that was a real point of anxiety and concern. So just as highlighted in the quote on the screen there, that I'm not at that stage, but to be honest, I wouldn't know where to turn to if I needed it. I don't feel as if I've got anything I can turn to and say, well, I know I can contact them, or it'll be easy to get help from. And just lastly, the impact of social, financial, environmental factors, including relationships with neighbours and neighbourhoods, access to gardens and space, comfortable, adapted housing, financial security, they were all raised as contributing and unequal factors that influence the extent to which carers felt able to navigate the changes to the care arrangements. And I think I'll just pass you over to Phil now.
Thanks very much. So Phil, we'll move to you to look at the evidence from the principal social workers and safeguarding leads. Thanks.
Okay, thanks Jane, thanks Debbie.
Sorry, it's not moving forward, Phil. Just hang on a second.
There we
go.
There we go.
Thank you.
Okay, so the majority of our local authorities confirmed there could be difficulties in identifying carers from our category of age 70 plus co-resident carers. This was for a number of reasons. Spousal carers do not often identify with the word carer. There is therefore often a mismatch between the language used and the actual needs of the spouse. There could be a perceived stoicism in older generations. You know, they were the war generation and don't complain. There was also difficulties arising from a stigma in some communities around the symptoms of dementia and the identification of an individual or relative with dementia. As a consequence of these difficulties, with our category of care that we were looking at, some local authorities had sought to actively identify carers through working with agencies who were in direct contact with communities, such as mental health services, admiral nurses, and employing carer support workers. However, numbers of carers coming to the attention of local authorities dipped for most in a pandemic, at least at the very beginning. As a consequence, the existing problem remained that many carers remained unknown and often did not come to the attention of a local authority until they were at crisis point. As stated by one principal social worker, they only knew the ones they knew. Okay.
Sorry, Phil, there's something wrong with my computer. There we go.
Yeah. So at nearly always the request of a couple, home care stopped or was refused. However, thanks to an unintended interaction with a furlough scheme, family members were often released from the commitments of their day job, so they were able to step in and assist with the care. Additionally, this unexpected reduced demand resulting from couples stopping or refusing home care provided some slack in the system. After often satisfying themselves that the alternative care was appropriate, most local authorities reacted to being advised that home care was no longer required by sending a letter to the service user, confirming care had been withdrawn at their request and requesting that the service user gets back in touch with the local authority if there were any problems. Unfortunately, and likely as a consequence of the strains on the system, there were only few instances of further regular follow-up following the provision of this letter. This was even though, although it was reflective of the strains of the system, and with our category of care, there was the knowledge that they did not often come to the local authority's attention until at crisis point, presenting themselves in hospital or somewhere similar. Okay, so yeah, Care Act assessments changed in their delivery during the pandemic. At the time before the pandemic, nearly all Care Act assessments were being performed in person. At the time of the first lockdown, however, nearly all Care Act assessments were moved from in person to remote assessments. So, for example, telephone calls, video calls, Teams, WhatsApp, and FaceTime. This can be contrasted with the Mental Health Act assessments, which after a legal challenge in January 2021 had to be undertaken in person, regardless of the pandemic conditions. Multiple challenges arose to the services users through this change towards remote access. This included using the technology itself. Those with cognitive difficulties and sight and hearing impairments found the virtual medium difficult to work with. Local authorities also relayed the loss of the ability to see or hear what the situation was in the home, and also confirmed how technology didn't always allow for a closer intimacy in discussions. For these reasons, and whilst acknowledging that for some categories of service user, virtual assessments worked, a clear aspiration was relayed that face-to-face assessments should resume, particularly for the category of carers we were concerned with in this research. The interpretation of the easement legislation differed across local authorities. Although experiences were similar, easements were differentially implemented and the majority was soon revoked. Some of the reasons for easements to be invoked included an actual or anticipated diminishing capacity of a workforce and therefore a consequent need to reprioritise services. This was the most common reason, but in most cases, the anticipated diminishing capacity did not actually happen. Another reason was the closure of day centres, which was widespread across all local authorities, as was an inability to offer a choice of care home provider or preferred accommodation. Other reasons included the inability to send written communications by post and the inability to offer annual reviews. As already mentioned, many of these were common across all the local authorities in this study, in both easement and non-easement areas. The main difference, therefore, appears to be in the legal advice that was provided within the local authority. Our research also found that professional networks such as ADAS and PSW network, as well as at least one contingency exercise pre-pandemic involving more than one local authority, are likely to have been influential in the decision-making of local authorities when deciding or not deciding to enact easements. So responses to the easements. Easement and non-easement local authorities faced different responses. The local authorities that did not enact easements didn't face any political, legal, or regulatory consequences by not doing so. There were, however, stressful consequences for the local authorities that did enact easements. They faced attacks from the media, public pressure, and legal threats such as judicial review and freedom of information requests. There was a difference in opinion over easements between those local authorities that enacted easements and those that did not. Easement local authorities believed that they were doing the right thing, the moral thing, and acting transparently and in the spirit of the legislation. They were shocked and surprised that other local authorities had not enacted easements as well. Non-easement local authorities, however, suggested easement local authorities had jumped too quickly and should have waited. What was evident from the discussions, however, with the easement local authorities is that they felt more could have been done nationally to protect them from the numerous attacks that they had faced for making this decision.
Sorry, Phil, I am trying to advance it.
Okay.
Just give me a... There we go.
There we go. So the differential treatment of health in comparison to social care was evident throughout the pandemic. Many principal social workers and safeguarding leads lamented upon how, particularly during the pandemic, social care was seen as less valued, receiving less investment and little support. Unlike social care, the NHS were able to make service rationing decisions on a daily basis without the need for statutory intervention such as easements, or incurring the same political and public pressure. Decisions made by the health service also impacted negatively on social care, such as the discharging of patients to social care in order to free up beds in the hospitals. There was little or no recognition how, with proper resources and investment, social care could have done and could still do early preventative work to save future health costs. Throughout discussions, there was a great deal of resentment towards the perceived prioritisation of health to the detriment of social care. Our research found, and it's well documented in other research, that social care is facing increasingly critical staffing resources. As a consequence of a multitude of issues, including, but certainly not limited to, poor pay and uncertain hours, there has been an exodus of home care staff to the retail, leisure and hospitality sectors. Social work staff also faced isolation, having to work from home during the pandemic, with a lack of in-person support There was no opportunity to have a chat in the kitchen or corridor over a cup of coffee with a colleague. Due to these pressures and the pressure of a whole pandemic, social care has and is facing significant burnout in the workforce. We were informed the social care workforce is leaving in droves and encountering major difficulties in recruitment. The position at the time of our interviews in late 2021 suggested that social care was in a worse position then than it had been in the first year of the pandemic. Social care was and is therefore facing critical stresses in carer support and provision, raising the issue whether mitigations and derogations from usual care in the pandemic are continuing in the circumstances now prevailing. Neil will consider in the next couple of slides the legal aspect of this issue.
Just before we turn to Neil, can I just say, because I know a lot of people joined us after the first few minutes introduction, just to say that we'll be conducting Q&A through the chat function. So if you have questions that you'd like us to answer, please do post them in the chat as we go along, and Jane McDermott will be keeping an eye on those for us. So thanks very much, and over to Neil.
Thanks, Debbie. So looking at what happened from a legal perspective, put very simply, the Care Act approach provides sort of 4 stages. The first stage is to assess the needs of the cared for person or their carer, where it appears to the local authority that they need to be, that they have those needs. The second is to work out and determine whether those needs are eligible for support. The third is to then meet those eligible needs if the various financial charging conditions are met. And then the fourth stage essentially is to draw up a care or support plan detailing what the person's needs are and how those needs are going to be met. So those are the 4 main stages of the process under the Care Act. And throughout all of that, there's a duty to promote the well-being of the individual. So in this slide, we ask somewhat provocatively, perhaps, how did those local authorities that did not rely upon easements, how did they act lawfully when the inevitable increase in the appearance of need, whether that's for care or support, could not simply be assessed? Sections 9 and 10 of the Care Act contain statutory duties to assess need where it appears to the local authority that either the cared for person or their carer is in need of care and or support. And obviously the pandemic inevitably increased the appearance of need, but in many cases, from our research, it seems that those needs could not practically be assessed. So how were those duties complied with in that scenario? Secondly, how did local authorities that didn't rely on easements act lawfully when the eligible needs of the cared for person could only be met by attending a day service, given that those services were closed, or needs could only be met by home care services, which in some cases could not be provided in a safe way or at all? Under Section 18 of the Care Act, that contains the duty to meet the eligible needs of the person that's being cared for. And in many cases, the carer or other family members on furlough, for example, did step up to meet the cared for person's eligible needs. And in that situation, a local authority is not required to meet those needs if they're being met by a carer who is willing and able to do so. But a care plan will be unlawful if it assumes a level of input or seeks to impose an unreasonable demand on an unwilling carer. So in those circumstances, how was that statutory duty complied with? Now, our research is obviously focusing on the needs of the carer, which is very much governed by Section 20. So how did those non-easement, the vast majority of local authorities, act lawfully when the carer's eligible need for respite, for example, could only be met by the cared for person attending a day service or having a sitting service at home or being in short-term residential care, given in many scenarios those were simply not available. According to the Department of Health, when this was first introduced, Section 20 creates a clear and enforceable legal duty to meet the needs of carers. And this was carers' first ever legal entitlement to public support, putting carers on the same footing as the people for whom they care. And even if carers did step up, as our research suggests they did, to meet the needs of those that they were looking after, what about those eligible needs of the carer? Those, in many cases, seem to have been left unmet. And of course, the more carers provide care, the greater their own needs become. The survey in particular shows that their physical or mental health was at risk of deteriorating or had deteriorated to a point which then significantly impacted upon their own well-being. The next bullet point, again, is a similar point, this time in relation to befriending services or other sorts of support or activities to alleviate loneliness or social isolation. Again, if those were eligible needs of the carer and they could not be met, how did these local authorities act lawfully in those circumstances? And then the subsequent and final bullet points are more specific points, really, but again, they relate to the statutory duties under the Care Act. So how did the most local authorities act lawfully, given the change in circumstances, which would no doubt have affected the care or support plan? Because under Section 27, that requires a reassessment and revision of the care or support plan when there has been such a massive change in circumstances as the pandemic would have created. And then finally, you might consider this to be a small point, but it's important when it comes to knowing exactly what's happening. Section 12 of the Care Act requires that a written record is given to the person. Now, that can be done usually by post, but of course, many office buildings were closed at the time. So how were carers and those cared for provided with a written record of this assessment process in those circumstances, particularly when those assessments could not be emailed? Next slide, please, Debbie. Now, obviously, our research is looking at quite a sizable number of people, but the State of Care report that was published last October gives you a sense of scale on a more national level. And this report says that about 500,000 people are waiting either for an assessment or waiting for their care or for a direct payment to begin or for some sort of review of their care. Thanks, Debbie. You can open up all these bullet points. The second interesting thing about the State of Care report is that 61% of local authorities that responded said that they are having to prioritize assessments and were only able to respond to people where abuse or neglect was highlighted, for hospital discharge cases, or after a temporary period of residential care to support recovery and reablement. Now, on the face of it, that is a significant recognition, it seems, that there is rationing going on in social care. They also found that in the first 3 months of 22, 2.2 million hours of home care could not be delivered because of an insufficient workforce capacity, leading to unmet need. Again, how can that take place without recognizing a breach of statutory duties? And then the report also refers to the Nuffield Trust report, which described how a reduction in staff is fueling an invisible care crisis in people's own homes, with many unable to access the care they need, increasing care burdens on unpaid carers and impacting on hospital discharges. And of course, our research essentially is looking to make the Care Act duties more visible in the context of what's seen as a hidden group. Debbie, over to you. Thank you.
Thanks very much, Neil. And I apologise to everyone for my computer not advancing the slides very timely. So I've just got a couple of things to say, and then we'll, as I say, open up to Q&A. Please do pop any questions in the chat. I can see some very complex questions have already been posted there. But really, just a few headlines, and please do read the report for a much more in-depth discussion of these. That obviously we're saying carers have suffered very greatly in the pandemic. That the easement legislation, quite interestingly, created incentives to challenge the invocation of easements rather than to challenge deficits in care. And within that context, the legal advice to local authorities really varied very widely. Our research suggests that given the experiences of carers that we observed and the legislative framework, we are clearly suggesting, but pretty unambiguously, that from a legal perspective, we think that easements ought to have been invoked much more widely. Although that would only have exacerbated the comparison with social care, with healthcare, which required no such engagement with legislation or policy. So the very big question is, were statutory duties met? And are statutory duties now being met? We suggest that our evidence from carers suggests broadly that it is very likely that statutory duties were not met throughout the period of the pandemic, and our survey took us right up until mid-2022. But we also, and in accordance with a lot of other people who conducted research now, know that it's highly likely that many people's eligible needs for care are not being met now because of the difficulties facing the social care sector and the social care workforce. So there are a number of questions that arise from this. From whose perspectives do we assess whether needs are met? Well, the Care Act is very clear that it's the needs of the person that are assessed as eligible, but taking into account what they actually need. But what are the consequences of not meeting statutory duties? Because if there is now a widespread difficulty for local authorities in meeting statutory duties, is the Care Act imposing those statutory duties, is it appropriate? Or what would the consequences be of having a discussion about that? Which raises the ultimate question is, are these duties now without de facto remedy? So the legislative logic and plan here was for the most extreme care and life-saving care needs to be prioritised, and protection appropriately given to local authorities who could not do all under pandemic conditions. But what's really unclear is what the longer-term plan for unmet care needs in a prolonged pandemic situation was. And to some extent, this was unintentionally saved by the furlough scheme, but furlough ended and also may not be available in future crises. Clearly exposed, as other researchers have also done, serious problems in the proper resourcing structure and workforce support coming from central government for social care. I think the other thing which we spent a lot of time talking about amongst ourselves on the project is that we're suggesting that the rule of law here has been undermined. And we ask what implications this has for the integrity of the Care Act, where the ability to meet strict statutory duties is just insufficiently resourced from the centre. We conclude by thinking that there are few to no practically accessible and effective remedies for perceived poor quality home care, and this is a topic that we're hoping to pursue in future research. So on that point, we have just about 15-20 minutes for Q&A, and hopefully we'll pick it up from there. Just to say on this last slide, these are the 4 documents we've published. At the end of the report, the final report itself, the appendices, and then a 3-page executive summary and a 1-page summary for people who need that high level. The project website is there on the slides, and as are all of our emails. And if we don't reach any questions in the Q&A, we will try and respond to them privately. So I'm going to say to Linda to please stop recording. We won't record the Q&A. And to Jane to perhaps